Welcome to Planetary Health First, Mars Next. It is an amazing day today, and we have a physician, Mick Connors, and he's no stranger. I guess if he was, he's been really getting prolific on LinkedIn, writing some super cool articles, one of which caught my eye, that Pinocchio article. And we're going to just get into some deep dives about the power of relationships, the power of the need and relationships and healthcare. And from a physician's experience as a provider, he's currently serving as an advisory board member, Remy Health. He's a founder of his own consulting group, and he's really leading as a thought leader. And we're really excited to have him on. Mick, Dr. Connors, it's so great to have you on. You want to share just a little more about yourself before we deep dive?
Yeah. Thanks for the introduction. Thanks for the invitation. It's great to be here. Always fun to talk healthcare, and there's certainly never an end to how we can consider changes to our healthcare system for good and bad. So I'm happy to be here. I'm a 30-year pediatric emergency medicine physician by training. Have done a little bit of everything in healthcare, including starting my own company, starting a tech company, starting a practice, employing physicians, being an employed physician, working in academics, working in private practice, and currently working as a locums doc where I travel to places that need pediatric emergency physician coverage. So, I love bringing this perspective to folks, which is really building my own perspective as I entered healthcare without really any healthcare experience or knowledge other than kind of seeing my own pediatrician. So my inspiration was a brother who passed away from pediatric cancer before I was born, and my mom telling me his stories about how she thought care could have been better for him. So I think that's kind of been stuck in my bone marrow and leads me to kind of this voice in the wilderness approach of my career, trying to make care better for kids.
Well, there are some, and there's very few that lead an impression on us throughout our lives, next to maybe our kindergarten school teacher, our coach, basketball, high school, whatever. But the pediatrician, I can remember my pediatrician's name. It was like a rite of passage every year to see that pediatrician, next to the priest, the social, so it's such a powerful connective part of family and just the guidance. So I really appreciate everything you've done. I received an amazing pediatrician experience, and it's hard to believe that his name, believe it was Dr. Rogers, not to be confused with the real famous Mr. Rogers. But anyway, that's kind of what, so I wanted to just, before we get into, I just really wanted to highlight some of what you had an amazing article about, just wanted to just highlight some of these points that I thought were really powerful, and you got a lot of activity engagement on LinkedIn. And I'm so glad you're doing this, that you shared, you're maybe not right brave yet enough to write your book, but I would say write it. That's why there's Kindle Amazons there, and whatever. But let's start today on some of those points that were in that, the electronic health record misconception. What did you mean by that?
Yeah, I think really, I've practiced long enough to be on paper, and then to go to various and worked with just about every electronic health record out there. Paper was not easy. Paper, we didn't have any electronic. We didn't have any past history. We didn't have, we used to send security guards to medical records to find an old record on a chart. So there's a lot more upside to the electronic record than is told. Also, the fact that really, I think the challenge with the electronic health record is it's pulled us away from, kind of the common theme of today, which is how do relationships tie in here. So I used to talk with the front desk. I used to talk to the nurses. We used to exchange ideas on what orders to write, how to write, what we were going to do, what they wanted to do. And with the electronic health record, it's kind of taken away a lot of that communication, that relationship between the patient, the physician, and the like. And I think the biggest misconception is that we're tied to it. I've never recorded a visit with a patient in the room. And the last company I worked at, that was a mandate that the physicians record their electronic medical record, just kind of save time. So I think we create a scapegoat around the electronic record when it's really up to us to better communicate with our patients, with our nurses, with our staff. And I think it's really kind of a cop-out just to keep blaming the electronic record myself.
And then the employment hierarchy paradox.
Yeah, I think again it's interesting because again I think life is centered around perception and experience. So from my experience, I've done just about everything on the employment side, right? So I've hired docs. I have been an independent contractor. I've been an employed physician. I've been part of a multi-specialty group. I've been part of an academic center. And I've hired folks all along the lines. And I really think, being employed or not being employed, who you're working for, if you're private, nonprofit, for-profit, none of those things really kind of matter. It really comes down to the culture and the relationship of the organization, right? Coming back to relationships. So, you can be very happy as an employed physician if you're working with the right group. You can be very unhappy as a private physician if you're part of the wrong group. So I think we focus too much on whether employment is good or bad, as opposed to really the underlying things below the surface that really determine whether we're happy, unhappy, and whether we are delivering great care and feel satisfied with what we're doing. So again, I think it's a nice crutch to lean on to say, hey, I just need to be private and run my own ship, and I need to be direct primary care where I'm just doing my own thing and in control of everything. But in reality, physician's role is really more of a sphere of influence, and who pays you and how you get paid certainly dictate how you practice. But it's more about the culture and the relationship of that than whether I'm employed or not employed.
I like what you just said, culture. The whole time you were talking, all I was hearing was culture. I mean, you can have a culture, Amazon day one, where it's trying to, delight and be a startup mode, or you can, and still they're trying to do that. You talk to Amazon workers. I know they have their own issues, but you can be at a startup that is like, we're doing everything by the book. And what book? So, and that they're not innovative. So it's just really, it's all about a culture is what you're getting at. So that's awesome. I'd like to move on to the scope creep next.
Yeah, I did an article just this week on kind of again, we kind of talk about scope creep, and we kind of point fingers at nurse practitioners, physician assistants, others that are kind of creeping into the physician space and are taking over more of our roles. What we don't talk about is how physicians are kind of creeping out of a lot of roles. And, as we don't take after hours phone calls, as we don't accommodate our patients that need to see us, as we continue to kind of silo into a 9-to-5 workflow, we kind of open up some of these areas for others to creep in, whether it's private equity, whether it's nurse practitioners, so I just think we have to really try to think about, how do we form teams? How do we form, again, it goes back to the culture and the relationship that we can all work together for what we want, as opposed to just saying, well, I don't want to do it, but I don't want you to do it either, is kind of too often stated or unstated in medicine, where, hey, I don't want to do it, but I don't really want you doing it either. So there has to be a little more, as to what you said earlier, a deep dive into, hey, wait a minute, what really is scope creep? And for me, it's less about the scope and it's more about, just the variation in training and abilities that folks have that are filling roles that they really don't want to fill, but are kind of put into that don't really match what their training or experience is. So again, I think we need to talk less about scope and more about, how we can creep towards better training, better experience, and better alignment, as opposed to just saying, hey, if I can't do it, then I want somebody really trained and experienced. I'm willing to train them to get them to the point that they're at, as opposed to just saying, well, they shouldn't do it. Right. Mm-hmm. So in medicine right now, there's a lot of pharmacy talk. There's a lot of, hey, we should have doulas. We should have midwives. Hey, all these folks can contribute to a team-based care approach. But, I think if we talked about how do we align strengths with strengths as opposed to who's doing what they shouldn't be doing, we'd probably have a stronger healthcare system.
Mm-hmm. Yeah, no, you're absolutely right. It's such a frustration. I mean, I can just say with myself, when I go to the doctor, um, getting the lab work doesn't talk with their chart, even though it's 3 floors above. And then every year, the insurance says we don't want to work with CVS because they're a mammoth. You got to go down to anyone but CVS to get a new pharmacy. And I never find this out because I don't talk to my insurance. We don't talk that way, right? They don't call me up. Hey, Mike, how are you doing? No. I find out the first month when they're like, oh, your medication that you had now is like 5x more. Like, what are you talking about? You know, so I mean, I like the problem also is from the patient perspective that and none of you as doctors, clinicians really have an eye into that too. So I feel for you in scope creep. So it's like this holistic design thinking that could be another thing, but that's a whole nother chapter, a whole nother book.
Yeah, no, I think that's great. I mean, I think really that's what you're hitting on is kind of the driver of scope creep, meaning that as a patient, I can tell you my experience is horrendous, right?
Mm-hmm.
And I don't know a physician that says, man, healthcare is really great and we're delivering great things, right? And so the challenge that we create is so many barriers for the patient that they are kind of told, hey, just go to this. It's fast, it's convenient, it's drive through. You can get what you need and you can kind of bypass all those things. And again, what they miss out on, and again, I point fingers at physicians, at practices, at all of us, what they miss out on is all the intangibles, right? I think you talked earlier about remembering your pediatrician and who they were, right? Well, if your pediatrician was so hard to get into and somebody said, hey, just go online and you can get that, whatever you think you need, you're probably going to do that. The problem is we all lose in that, right? So we, rather than align pharmacy and align nurse practitioners, align physicians and align that care, we just have created this fragmented system based around convenience and access, which again allows for scope creep because we just want things quick, but really doesn't solve the problem. It's more of a workaround. I lost your audio. Sorry.
Yeah, well, that helps if you're actually not mute. Yeah, so I was all excited saying I love every like tagline, the in-person care illusion. These are chapters in your future book, and you know, go ahead.
Yeah, no, I think in-person care is a great example, right? I mean, we have for my 30 years really a great value in the telephone. So this idea that we can't deliver care via telephone, we can't talk with our patients, we can't add video to that telephone call and deliver great care, again, has little to do with whether we're in person, whether we're out of person, whether we're over the phone, whether we're over video. It's who you connect with. And the great lie that an illusion that's been created is that, again, randomness, quickness, convenience can trump how you're cared for as a person and as a patient. So I want to connect with my doctor. I want to connect with my pediatrician, and my pediatrician may feel like the only way they can get paid or be efficient is to have in-person care. So again, on both sides, we create these crazy illusions that in-person care is better. Really, it's who you see and how you see them and in the way that you need to see them. I went and had an orthopedic appointment and never got an exam. And we had a great chat on what surgery I should have and how I should do it. Why I needed to drive 30 minutes, wait 30 minutes, and other than to collect my copay, which I guess we can do online now, really didn't make a lot of sense to me. So again, if we're going to be patient-centered and person-centered, then we should meet the patient where they need to be and not necessarily, be for or against one thing or the other. I mean, telephones. I love calling patients after I'm worried about them in an ER visit the next day just to see how the heck they're doing. I don't think they need to drive to the ER and wait in the waiting room to see me again, right? So I think it's, again, both sides, patients and physicians and practices could come together and realize, really delivering care is about who you connect with and not really about the mode of connection.
Yeah, I had another Dr. MD on my show, Adam with Nerds MD, and one of the things he was mentioning is just people want to know. Like, it's like one of the problems with healthcare is just let us know what's the status of your appointment, what's the need. And that's the siloness. It's just like there's no connectivity. It's like just the fact we will get back to you, we have your input, we're looking through your record, we'll get back to you in 24 hours. Almost just like a Zendesk, simple, not violating HIPAA. I mean, we're just trying to find out. I
Yeah.
mean, it's like a no-brainer. I would happily have my 14-year-old daughter figure that out for a school project, automation and communication.
Yeah, well, you can go back 25 years, and it's why I founded Anytime Pediatrics with the naive notion that patients wanted to connect with their physician and their physician wanted to connect with them, right? Because if you go back 25 years and you look at nurse telephone triage, there's great data and evidence that, just calling your practice and getting a hold of a trained nurse, you can reduce that anxiety that you're talking about 85 to 90% of the time. 85 to 90% of what I do in the ER is reassure folks. Thankfully, it's not, major trauma, right? Everything else. To your point, it's a worried parent who's reached the point of, hey, I don't know what's going on. I need help. And I can either, I've already been to the retail clinic or the urgent care or the online MD and didn't really get the straight answer. And I really want expert care. But really, a lot of it is, hey, you're going to be okay. Your kid's going to be okay. You can go to sleep tonight, right? Is the bulk of what healthcare truly is, right? It's caring. It's not prescription writing. So, again, in person, over the phone, it's what the patient needs and how they need it.
And Mick, is the biggest problem practices like if there's a percentage, let's say 70, 80% of them just cannot do this outside stuff because they're just worried about the revenue, the reimbursement model? What is the biggest barrier, you think, from practices being that type of mindedness to get the things done outside of the walls of their visit? Is it just they fear?
Well, I think it's the evolution of our fragmented care system, right? So it's really, we've really tried to make things easy. And in the end, we've made things a lot more difficult, right? So, again, 10 years ago, most pediatricians got 3 calls per pediatrician per night. So if you had 4 docs in your practice, you'd get 12 overnight calls. Well, now that you have retail clinics and urgent cares, you get maybe 1 call, maybe no calls. Part of you likes that because you get to sleep. The other part of you hates it because you spend the next day tracking down to see where your patients went and how they went there and what they're on and following up their prescriptions and those kind of things. So I think this loss of continuity is probably the biggest driver. And I think it's also the idea that, working less makes us happier when actually our burnout is increasing, right? So there's ways that we could create. Nurse triage is a great example. A lot of pediatricians don't use nurse triage because they can't afford it, right? And they have to pay out of pocket, say $15 or $20 for a phone call for their patient to call them to get the nurse to be able to handle the call after hours to give them a break. But at the same time, these same patients will go spend $150 or $200 or more for another visit, right? Because there's not really an alignment, to your point, of the payment system. If we went to a value-based care model and you got paid to keep your patients out of the ER, you would probably have nurse triage, right? If you were happy sleeping and your patients were happy going to retail clinics and getting whatever they wanted, why do you pay for it? So we're kind of, I think that's how our outcomes worsen and our cost increase because we've lost the value, perceived and real, of the value on both the patient side and for that physician or practice side. How do we meet that?
Well, going back to your awesome article, artificial intelligence misjudgment, man.
Yeah, I mean, AI is the buzzword. So I think if you write an article, you got to put it in there, right? But I think the challenge that we see with AI is, again, we're not using it to talk about everything that we've talked about, right? We're not talking about, how do we create continuity? How do we create relationships? How do we foster better care? How do we reassure patients? We're really talking about adding another layer of replacement to what's not working and using it as kind of a workaround. So now, instead of calling your office and getting a phone tree and getting a voicemail, now we're gonna text a chat bot that's going to tell us that we need to call the office. That's then going to you know what I mean? It's just kind of like adding the layers of the challenges, when in my estimation, artificial intelligence could be a great tool if we continue to build it to a line of how do we foster that continuity of care. and ensure folks get to the right place at the right time and are able to utilize it in a way that makes sense, right? As opposed to, hey, I see AI because we can reduce the number of nurses we need. We can have virtual nurses. We can have chatbots. We can have all these things that are, again, moving us farther away from the things that we know that work, which are continuity relationships, and more towards tech that kind of distances us from that human touch that we need in one way or the other. So I think, again, the investors, the private dollars, kind of like I see the same thing happen in telehealth, where the investment dollars went to the quick workarounds and failed. And now you probably read plenty of articles where digital health didn't match up and it failed and the technology is the worst. The fact is we didn't use it correctly, right? We didn't develop it correctly. And that's my worry for AI as well, is that we're gonna use it in places that the frontline folks don't really want it or need it. And we could be using it in other places where it really could benefit a great deal. I mean, we talked about nurse triage. If a nurse could pick up a nurse triage call and have an AI be able to assimilate all the medical records and say, hey, this child has a fever and that's why they're calling, but hey, they also have a history of leukemia. Let's bump them to the top of the list, or it can identify those patients at higher risk. So I'm treating them more quickly and adeptly. That's where we could really benefit from more of this machine learning and AI kind of things, as opposed to just, hey, let's just use it for process improvement that really will fit into just more dissolution.
Don't worry about seeing this health universe. It isn't in the story. It just associated what you're talking about is a company organization. I had him on earlier, Doug Fritzma. He's the CMIO at Health Universe. Dan is their CEO, and Health Universe is an open source AI. So they have anyone and everyone that has a data solution. They upload using mostly Python, and it's all about open source AI all the way to FDA approval. And so it's peer reviewed. And so it's using user case. And so I think when I'm hearing what you're talking about, my biggest worry with AI is that more harm than good. I mean, like, the rule number one is that we have to do no harm to our patients, our health systems. And my gosh, it just worries me greatly. I'm not a Luddite. I'm not a technophobe or whatever, but my gosh, we really need to have a designed approach, really smart. We need to sandbox it. We need to test it. And that's really what they're trying to do, is make sure that they're doing that in a safe way with different approvals and different levels, and just activating it through different community groups. I mean, imagine if caregivers had their own little thing that they tested within a certain population that could help allow using AI to access decision support for that certain need, or a cancer group of population, or with a rare disease. So to me, that's anyway. So I'm going to stop there, but that's sort of what I'm hoping we'll see more of with AI in healthcare.
Absolutely. I mean, what a phenomenal population health tool. What a way to design interventions around. What a way to reach, kind of undo or try to undo some bias within the data that we have. But on the flip side, there's certainly opportunity, as we see with social media and digital health and electronic medical records, which is just a data gathering tool for folks to target the folks that can drive more revenue. Right. So it always comes down to mission and culture and kind of how you use something as well.
And the myth of solo excellence.
Yeah, I think, I'll give you a funny story on this one, because I think it really resonated with me when I was a pediatric emergency medicine fellow and I got asked to be a sideline physician for a high school football group. I'm like, oh, this will be fun. I get paid, I don't know what I got paid, $20 or something, to kind of be on the sidelines because they needed physician coverage. And, it just kind of struck me and made me laugh because, a kid got injured on the field. I mean, he was fine, but it always, I go out there and I'm, with no tools, no equipment, just kind of go out there, see how he is, examine his knee. And it kind of gives you that idea that, man, I'm really not as smart or as good a physician as I thought I was. especially if I don't have my nurses, I don't have lab, I don't have radiology, I don't have all these tools in the toolbox, that I need in order to deliver great care. And I think as a pediatric emergency physician, that probably resonates the most for me because, I'm only as good as the nurses that I have around me. I'm only as good as the culture of the environment. I'm only good as the mission of the hospital or the organization, right? And I think sometimes we physicians think if we run farther and farther away onto ourselves, and we get the MBA, we get the MPH, we get the accounting degree, we could do everything, right? I mean, that's kind of how we're trained. Is we're kind of the not only the quarterback, but we are the team. And in reality, we really need to be the quarterback and recognize, man, Tom Brady would not be, a future Hall of Famer without a great line with great backs, great coaches, right? And for us physicians, we tend to silo ourselves off. So I think the more we can build this team-based care approach, and the fact that we're, an important cog in the wheel, don't get me wrong, but that we need great people around us and not, and embrace that and not be threatened by it, I think we would do. We deliver much better and more excellent care. So I'd love to see us coalesce as opposed to continue to kind of silo off into specialties and thinking about physicians needing to lead everything, as opposed to building that sphere of influence and realizing we're better in a team than we are, by saying, hey, it's docs versus the world kind of thing.
So that would be more like a team-based decision-making approach.
Yeah, I mean, I always laugh. I mean, to me, it's about aligning strengths with strengths, right? Mm-hmm. So whether I did pediatric emergency medicine, I did pediatric sedation, or when I did telemedicine, or when I look at anything, it's how do you get the right patient to the right place at the right time with the right caregiver with the right treatment modalities, right? So that's really what care is. That's in the old days, we used to call that the care continuum. Where, a worried mom could handle things. I mean, they're the first and primary caregiver for that kiddo at home, right? They reach a point where they need help. They're going to call the office. The office is going to say, do this, and even as physicians in the office or even in the ER, I don't take care of everything. I call the next physician who has additional skills that I don't have, to take out an appendix, to, operate on a neurosurgical case, right? So what we've lost a lot in this solo excellence is everybody is good as anybody, and anybody is good as everybody, right? And unfortunately, it's just not the case. So it's about aligning that skills with what patients need and what we physicians need, right? I mean, physicians have flocked more and more to employed large systems because we love all those resources around us, right?
Yeah. So Mick, I'm thinking of like ChenMed, Village MD, Oak Street. A lot of these are these Medicare Advantage value-based play that really I'm hearing that resonate, that seem like they're wraparound holistic. They bring those seniors in once, let's say once a month. They do all the pharmacy, they do all that. Am I on the right track? Are you aware of those? Am I saying the right ones that kind of are trying to, they're essentially answering that problem of the myth of the solo excellence?
Yeah, I mean, I think you're spot on. I mean, I think there's certainly lots of companies trying in this space. Again, it comes back to, what's going to be most effective and who's going to win. In my mind, and I'm biased, as I've said over and over again, it's the organization that recognizes that relationships and continuity win, right? So it's not going to be the organization that has the most gizmos, or that sets up next to a pharmacy, or that runs a lot of tests to drive revenue, or there's different ways to kind of do this, right? So I do think value-based care is the future. I'd love for us all to be value-based care, because I think it really changes your mindset, both for the patient. I had knee surgery. Is that my surgeon operating on me because they get paid to operate on me? Or are they operating on me because I need an operation, right? My dad, who's passed away, he hated physicians. He thought we were all just ordering tests and labs because we wanted the money, right? And that perception doesn't help anybody. But on the flip side, as a physician, being outcomes focused, focusing, to your point, on those patients that need us the most, and not just the patients we can see the fastest, is a misalignment in our system, right? So if we had AI that identified the patients at higher risk, the demographics at highest risk, the race, the socioeconomic things, and those were the focus, then we would have a different healthcare system, right? Instead, we tend to focus on fast revenue, more procedures, and those kind of things. So again, I think to your point, it's how do we get back to primary care? How do we keep primary care away from folks that are just wanting to profiteer off of a cool contract versus really deliver better care?
Yeah, I love that. I would love us to have some sort of demonstration, a Japanese model demonstration on you get paid after a year when your patient is well care, and they pay when you're well. And so I feel like where I'm right now, I have my checkup in June, and basically I'm supposed to be on a statin. I'm supposed to be monitoring my blood pressure, and so I've gone plant-based. And that's just me and my journey from my research, but I've already, I think the evidence is pretty powerful that sleep is the number one thing one can do, and they don't ask simple questions because it's just, and they can't give me an RD because I'm not have chronic disease yet. It's crazy. They can give me statins, they can give me all those things, but come on, if you're not, we need to have more peer-to-peer support to help patients. And that should be part of the wraparound with orders just as much as a statin. I mean, at this point, at least some way or another, as easy and accessible as a click, I feel. I mean, that's just my opinion as a patient.
Yeah, you're spot on. I mean, patient compliance, patient engagement, peer support, getting patients to actually follow the instruction of the physician and having a physician that's has an ability to influence that behavior change. And I've talked to a lot of physicians who are like, yeah, I just tell them what to do. If they don't do it, it's on them, right? Like there's ownership on both sides. I mean, that's the one challenge with value-based care is there's not a lot of skin in the game for the patient would be the argument, right? So, hey, you didn't go plant-based, you didn't do your research, you didn't take your medicines, you didn't do anything, and now you've got heart disease and hypertension, and the physician's at risk for your poor behavior, right? So the best way I can manage my contract is to get rid of you somehow, right?
Exactly. That's exactly.
Take all the high-risk patients and I move them aside. So again, it goes back to, how do we bring patients, physicians, relationships, continuity, culture together? It's, if you're going to drive through McDonald's and eat every meal there, it's really tough for me to impact you. On the flip side, if you can't reach me, you can't get an appointment, you don't believe what I'm telling you, it's going to be really tough to change your behavior. So we all have some fault or some skin in this, that if we want to stop being lesser outcomes and the highest cost around the globe, we should start looking at kind of what's working in other places.
I do think there should be an order for that. I mean, there's no reason why all insurances should not have a button. If they can order a statin, they should be able to order some sort of light. I mean, really, it should be both. It shouldn't be either or. My doctor explicitly told me, like the insurance. I mean, I don't know if he knows the plan, but I mean, I've done it on my own. I was motivated. My wife was doing it. So it really helps a lot. So I've done it over, I think the 14th I started. I've lost almost 9-10 pounds. It's not about losing pounds, but my gosh, I feel so much better. And really it's not just plant-based. It's cutting out those sugars, those high fructose corn syrup sugars, and then eating natural grains and vegetables. I mean, and then just being really focused and intentional and motivated. I have a motivation that June's coming up, my follow-up visit, and I don't want to be on those medications if I don't have to. So I just wish there was more alignment and help for doctors. I'm not blaming my doctor, but I probably am going to get another one because there are other doctors out there that are doing more alignment with transforming where we need to go. I'm kind of going off on that. So let's get back to the greed, the double standard.
Yeah. I mean, I think kind of, what we've talked about here is unfortunately, most of this is financially driven kind of thing. So, I give my dad credit for always keeping me humble of, hey, why are you ordering these tests? Why are you doing these things? I think as a pediatrician, we also, it's much harder to order labs and tests and x-rays on kids. I mean, we don't like to do all those kind of things. Whereas, perhaps in an adult, it'd be easy to kind of do those things. So, I just think, when you talk about nonprofits, when you talk about for-profits, we tend to go like, hey, they're greedy. When I started my tech company, even though I lost a ton of money, invested a ton of money, I was seen as greedy, and that's why I was doing it. Nonprofits are seen as having, their own motivations. I mean, the bottom line is, I think in the end, we all need to align around outcomes. And to your point, you got to have margins or you don't have any mission, right? So you kind of get all comers when you come to this, but unfortunately, sometimes the innovators, the investors, the folks willing to take risk are seen as automatically greedy, and those who, just kind of sit back are kind of hey, we're just here for the good of the people, but aren't really matching or meeting their goals as well. So it makes that focus on money more of a challenge. And kind of, I always talk to my private practice pediatricians. They're all corporations. They're all for profit. You look at the large insurers and they're nonprofit. Like there's just kind of an odd mix of real how we define greed and how it kind of plays out in the system. When I think most of us physicians would really prefer transparency across the board, margins and mission, and ability to grow and invest in what we need to do. Whereas others are just kind of taking that profit and hanging it out to shareholders. So there's lots of double standards in these discussions when we talk about greed in medicine.
Yeah, I think how you're resonating with an audience, because you're building a good audience based on what you're sharing, is your full humility, your transparency, and you as your credibility as a physician. I think people really are more and more really desiring these conversations. And the greed double standard, you see it all the time. I mean, like, think of OpenAI. What the biggest contradiction that Elon Musk and Sam Altman started a company, or this nonprofit to do good for AI, and then within a certain amount of time, I don't know, was it November of last year, $10 billion Microsoft invest in this not-for-profit OpenAI. So you're right with the not-for-profit status versus almost a more, they're like leveraging that. And so I'm really appreciative that you're actually putting it out there, making us have more of conversations about these things that often that are, or society or US does not really want to talk about. I mean, really, the most powerful organizations, insurance agencies, are not for profit, and hospitals. It's sort of mind blowing. So thank you.
Yeah, no, I think I think we all need to be a little humble and accept our part of the blame is kind of my deal, right? I mean, anyone who says they're not at fault for part of our challenges in the healthcare system is lying to themselves, I think, right? And whether you're private equity rolling up practices and then selling them for a bigger number, if you're not really taking care of the underserved population, if margins are over and above everything related to your mission, it's tough. There's lots of rhetoric around there.
The bias blind spot.
Yeah, I think this is a big one for me and something to really explore. And I've started to explore myself. I think there's just so many biases across healthcare that most of us don't want to admit, or, they're a blind spot because they're a blind spot, right? Like, I grew up in a lower middle class family. My mom had 8 kids in 10 years. My first exposure to, anything outside of a white middle class culture was when I went to medical school, or even, started seeing patients, right? Like, I have so many biases that I didn't know I did, right? We're all biased, right? We grow up in a certain experience and a certain perception. And I think as I've grown across my 30 years, I kind of am realizing how little I know that I didn't know, right? So, a lot of us will say, hey, we're not for profit, or we're about the mission, or we're about the margin, or, we treat every patient the same. And then the data comes out that shows that, Black patients get treated differently. And we're all like, oh, that can't be the case. I am the one who treats everyone the same. And I think we need those conversations as well. Right. I think those are hard conversations to have, but really I can, again, if I'm talking for myself personally, it's more about my ignorance than it is about my overt racism, I guess is the way that I would put it. Right. It's I don't know the culture. I mean, we now have, so many different languages that are spoken, so many different cultures that come to the emergency departments that I see. And I feel incredibly naive into understanding, what their concerns are, what whether they speak a different language, come from a different company, if they're migrants, if they're, legally here, all those kind of things. There's so many different ways that bias can rear its ugly head in how we treat things. And, the more we discuss it and are transparent about it, I personally find it helpful to learn, right? I don't know your background or I don't know your story, but man, I imagine if I knew your story or knew better about who you were and you knew better about who I was, and we could recognize maybe some more of those gaps or at least discuss them. Like, I think I'm doing all the right things. Like my number one intention as a doctor is to treat everybody the same, try to put away all those biases. I try to, whether you're poor, whether, in the ER, we treat everybody, right? You were the gunshot victim or you were the shooter. We're treating you, right? So there's no room for judgment, but it's kind of naive for us to think that we don't have some implicit bias or unconscious bias that are there. And so I enjoy conversations where I'm able to talk with folks that kind of give me a different lens on, hey, this is how I perceive this, right? There's just so much gray. And I think we want to be black and white. We want AI to tell us right and wrong. We want our politics to be blue and red, but everything is gray, and everybody has a different perspective. And where you come from and how you got here is all very different. So I think we have to be more open with our, biases, not that, if they were intentional, that would be one thing, but if they're not, we can still have biases, and we should be open to those conversations.
I think reflecting on my own challenges and failures in that is that every person is unique. And when I mean that, irregardless of their background and how they want to be identified, how they want to be communicated to, what are their triggers or what, and to me, there needs, this could be a whole company of companies on how to help within the healthcare system to create greater value. And I can only speak from my own situation. My wife was born in the United States, but lived 10 years in Mexico. And I have learned so much, and every day I'm learning about how she identifies with certain things in her culture and how it is. And I am totally from a totally different background. And so that is just one little node, one little data point. And I get it wrong every day. And then it's like, we need to help organizations, leadership, and in that patient doctor experience, tools, resources, the training to better listen, to better help those patients that they're working on to really get that communication line. Because right there, if the trust, this is all about trust. So, man, that is right there is like billions of dollars for companies in healthcare, talking about a digital healthcare. So anyway, I'll stop there. I don't have the answers. Obviously, I'm coming from my own perspective, but it's such an opportunity, I would say, to deliver better care.
Yeah, no question. I think diversity is an overused term, but diversity of opinion, perspectives. It's kind of why I started writing in the first place. Is I have a totally different perspective in where I live in the emergency department that most of the planet has no idea. Like that child abuse exists, that kids have bad outcomes, that poor children get treated poorly, that bad things happen to good people, right? Why you should wear a seatbelt, right? All those things that people take for granted or think they kind of have the answer. From an emergency department perspective, my learning just is never ending, right? And that perspective, I think, is something that more and more people that are, distant from the front lines need to understand as they're making decisions on where they invest, how they invest, who they invest in, right? We need racial diversity, we need economic diversity, we need all those things to bring those, cultural diversity, to bring those perspectives, because again, we're better together forming those relationships, having those conversations, than we are saying, hey, Mick has the answers and let's follow Mick, because he's got it all figured out. And that's kind of the, at the end of the day, that's why some of the, I'm trying to write the way that I am, is like just challenging that, there might be another perspective, and my perspective might be wrong. But I'm okay expressing it so you can understand and tell me where I'm wrong, as opposed to just saying, man, I'm just preaching to you. This is the gospel of what you think should be right. And I have found over my career that, again, the farther you get away from kind of that personal hands-on care, the less you really get the impact or the ripples of the decisions that you're making, whether you're an investor, whether you're, an administrator, a C-suite person, or, myself, I've been in leadership roles, and it's hard when you get farther away from things to think you're doing good things, but you got to go all the way down to the where it's impacting to really understand it. And I think we need more of that in healthcare and more medicine. And so we need more diverse perspectives, not just folks rising to the top because they say yes and they're quote unquote a team player.
You're right. Just talking the talk, but we're at the very last one. I think this is perfect. Value, vision, loss. And it's been awesome to have you on, Mick. And I would have never had you on if I hadn't seen your writing. I mean, it's really the reality is no one knows your thoughts, what you're doing, if you don't get it out there. And it also didn't hurt that I believe you're a great friend with a good friend of mine. Well, a great friend too is Susie Ingwald. I believe you guys resonate because you should have a shared passion. She is all about pediatrics and pediatric advocacy and innovation. So that always helps. And you were probably, gosh, this crazy guy, planetary health first, Mars next. What the heck is that? I don't know, Mike. But anyway, thanks for saying yes. And our last one, value, vision, loss.
Yeah, I think we've talked about it for the last 45 minutes or so, right? It's the value, right? Like what really are we after? We are better outcomes, lower cost, caring for more people, caring for more kids, getting better care. We've lost all that in revenue cycle management, fee for service, convenience, access, all these buzzwords that kind of drive me crazy on LinkedIn, where folks are, promoting how much money they've raised and very few articles on the outcomes that they've driven. Right. So we have to get back to where, where's the patient, where's the physician-patient relationship, where's the team-based care, and where's the outcomes? Because we're failing faster and faster as we spend more and get less for our money, both as a patient and physicians are, you want to be a physician because you want to provide better care, and you don't last long just running the rat wheel of fee for service. Hey, I could see Michael super quick. Let me give me 10 healthy Michaels through there so I can make more money, as opposed to the, Michael's coming in, he's really upset, he's depressed, he's down, he needs 45 minutes of my time. Oh, no, let's send him on quick to somewhere else. So we've kind of lost sight of that. And I think both from a patient and a physician perspective, continuity, relationships, culture, mission really needs to bubble back up to the top, because we're getting lost in this whole rev cycle, fee for service, more is more, and we're getting less and less.
Yeah. Do you ever see that you might start a company? And when I mean a company, I mean an actual, I know you're doing consulting, advisory work, but it just seems like sometimes, I've heard from through times, people that went into VC and all they did was keep on looking for companies they want to invest in. And then finally, well, geez, I got to do my own. I mean, that's what I'm hearing. I just don't know where you are in your place in life.
I founded a sedation practice, which was brand new in 2004. I founded Anytime Pediatrics, the pediatric telemedicine company in 2016. And I think, where you're hearing my voice is really I'd love to join or be part of a company that's really fostering value-based care in pediatrics. That's what I'm currently exploring, because I think what I've learned over my years, to your point, you can look at all these great companies, you can invest in great companies, but when it comes down to it, to transform care, to transform pediatrics, you kind of have to own it, right? You have to own the population. You can't just talk about, hey, we could do this and we could do that, or AI has this potential. You have to go out and execute. And so I think my next step isn't so much needing to have to be an owner or a founder, but aligning with like-minded folks that have the mission and vision that say, hey, we can actually make pediatric care better. We can move towards value. We can get kids better care, and we can get all kids better care, not just the kids in the suburbs and the right zip codes, right? Because it's possible. But execution is the biggest challenge.
Yeah, absolutely. And I know we're coming to the very end. The one thing I was curious about when you said that, now everyone loves value-based care, right? But a lot of it's on that 12,000. I think we're at like almost 13,000 a day, 65 plus, that huge population. Is there enough of a population right now where there are a lot of VBC programs out there for pediatrics? I'm clueless about that, just before we end, and then that's about it.
There's lots of opportunity. There's not a lot of execution, is the way that I would put it, right? Because when you look at the total cost of care at that first year of life, and then it's picking up on the screenings and development and things that we don't pick up on till later that cost us down the road. And then obviously 25% of our population is kids that then turn into adults that someday turn into 65-year-old adults. So I always talk about moving the curve to the left, and maybe it's my bias in pediatrics, but spending all our money on the last year of life, at some point we have to say, well, maybe if we spent, to your point, hey, I went to plant-based, I did whatever, I'm now going to live longer, healthier, keep moving that over, right? I'm influencing kids on that. What about prenatal care? What about teen pregnancy? What about, neonatal intensive care? What about complex kids? What about screening for autism and ADHD and learning disorder, right? All those things, if we continue to move those over and focus on kids, if we really believed in more than a 3 to 5 year turnaround on our investment, there was an 18-year or 65-year return on investment, we would see it. That's the question. Can we get there? Can we shift the mindset that our kids are more valuable than what we currently act like?
Yeah, Mick, I hear what you're saying is almost like really the great investment in our future. I mean, like the real deal. I mean, right now we just like the same reason I'm not blaming my doctor, but the model set that they don't make any money until I'm really, very sick. And preventative care, there's nothing that's like, whether it's through foundations or whatever, but it's unfortunate because now, they want to have kids on cholesterol medications and all that. I mean, it's just, so anyway, I do hope that you will continue to do what you're doing, get it out there, and you'll be able to be more involved to find those like-minded people that want to do the right thing. I mean, that's really what it is. We can't shortchange our future, and that would be the biggest ROI in our healthcare. I mean, that is truly a preventative care, so.
Yeah. I mean, it'll be, medicine's about the rewards that aren't financial, and that's my biased pediatric opinion, but it's true, right? So the burnout crisis, if we went back to focusing on what truly made us happy and why we went into medicine, and we started acting like that, it would probably turn things dramatically around. And part of that would be realigning the monetary system away from doing more and actually preventing more and caring more. But lofty goals, but hopefully, through more discussions and perspective sharing and less like-mindedness and more disruption, we can get back to really what we all want, right? As I can tell you, for me as a patient and as a physician, it stinks right now.
Well, Dr. Mick Connors, thank you so much for coming on Planetary Health First, Mars Next. It's been an amazing journey today. I hope you enjoyed it, audience. I really appreciate it. Peace be with you, and continue to follow us. And there will be more about everything Mick's doing. I will make sure we share in the post and the drop more links and articles to what he's written and what he's excited about. And please follow him. What's the best way to follow you, on LinkedIn or?
Yeah, LinkedIn. Keep it simple.